So which one of the following is most likely demonstrated by this angiogram? So hope I get some replies for this question now. So I've explained you about in brief about the cerebral angiogram. So you should be able to tell what you are seeing here. Yes. Okay. Good. Good. So it is MCA bifurcation aneurysm. So this is the anteroposterior view. This is the lateral view. So you can clearly see here, this is the ACA, which is bifurcating into lateral M1 MCA and the medial A1 ACA. So here the medial M1 MCA is then bifurcating into the superior trunk and the inferior trunk. It's here. So it's a classical MCA bifurcation aneurysm. So you can see that clearly in the lateral view. This is a superior trunk and the inferior trunk. So this is a classical MCA bifurcation aneurysm. So the proximal M1 segment aneurysms at the origins of the lenticulostriate arteries are exceedingly rare, but when present, they tend to point upward. See, there are 4 parts of the middle cerebral artery, which I will show you with illustrations now. So depending on the usual commonest site of origin of the aneurysm is at the bifurcation, because that is the point of the maximum force that the blood, that the vessel wall feels. So because of that shear pressure, the commonest site of origin of the aneurysm is at the bifurcation point, be it the basilar artery bifurcation or the MCA bifurcation. Wherever you see a bifurcation, it is a potential site for aneurysm. So the bifurcation is the commonest site, whereas there can be aneurysms in the proximal M1 segment, where the superior surface of the M1 segment gives rise to the lenticulostriate arteries. So if any aneurysms arises from the proximal M1 segment, the aneurysms will be related to the lenticulostriate arteries. In such cases, the proximal M1 aneurysms always tend to point upward. The dome points upward. Whereas if the aneurysm arises from the temporopolar branch of the MCA, then they usually point inferior. So there will be an inferior projection if it is from the temporopolar branch. It will be a superiorly pointing aneurysm if it is arising from the proximal M1 segment. If the aneurysm arises distal to the MCA bifurcations, it is quite rare, but it can occur in cases of infectious disease, which is called as mycotic aneurysm. Any aneurysms which arises distally, okay, distally, the commonest reason could be either infectious disease or traumatic in case of DACA aneurysms, that is a distal AC aneurysm. When you get aneurysms in A3, A4, and A5 segments of ACA, which is quite rare, that can occur commonly in traumatic or mycotic aneurysms or infective diseases. So the distal to the MCA bifurcation, if you have an aneurysm, suspect some infectious diseases. It's not a standard dictum, but it should always be kept in mind. So the 4 various segments of middle cerebral artery. So these are the 4 main segments: the M1, M2, M3, and M4. Okay, so it alternately it corresponds like you will have an horizontal segment, vertical segment, horizontal segment, and a vertical segment. So alternatively, you will have an horizontal, vertical, horizontal, vertical. So just like the various parts of the ICA. So the M1 segment, it is the sphenoidal segment. It begins at the terminal bifurcation of the ICA and ends at the genome. A right angle bend in the artery as it courses over a small gyrus of insular cortex, that is the Lyman insulae. So that is the genu. So M1 is not from the origin of from ICA to the bifurcation. Always remember M1. Many people think that M1 is up to the bifurcation of the up to its bifurcation. It is not so. The M1 extends from its origin from ICA to its genu, to the first bend which we get. Okay, so that is what is called as M1. The right-angled genu or right angled bend that is being taken. So the horizontal part is called as the M1. And then M2, which is also called as the insular segment, because now you are into the insula. So it begins at the genu, runs in the insular cleft. It terminates at the circular sulcus of the insula, where the arteries make their next right angle turn. Okay, so it is the second genu. So you get the second genu here. So M2 extends from the first bend or the first genu, and then it runs vertically along the insular, and then along the circular sulcus, it takes the next bend. Okay, it takes the next bend or the next genu. So this complete vertical part between the two bends or the two genus is the M2 or the insular segment. And then the M3 or the opercular segment, which begins at the genu, where the arteries leave the insular surface, and it runs in the opercular cleft. They terminate at the cortical surface of the sylvian fissure. So M3, it reaches up to the cortical surface. So that is M3. That is the opercular segment of the MCA. So this is again a horizontal segment which is extending between the second bend or the second genu and up to the cortical surface. And M4, M4 is the cortical segment. It consists of branches supplying the lateral convexity, and from their emergence from the sylvian fissure to their final territory. That is the M4 segment. So M1 is the horizontal segment from the IC origin to the first bend or first genu, and then M2 is the vertical segment which lies between the two genu, the first bend and the second bend. And M3, it starts from the second genu and extends up to the cortical surface. It is called the opercular segment, and this is called the sphenoidal segment, or the insular segment. And then the M4 is the cortical MCA. So this supplies the lateral convexities of the MCA. So the same various segments in the angiogram and the MRI picture. So this is again the anteroposterior projection in a digital subtraction angiogram. So this is the M1, the horizontal segment, and then the first bend comes here, the first genu. So then is the M2 or the insular segment. So this extends, this is a vertical segment, and then the second bend or the second genu happens here. Then there is the M3, which is the opercular segment. It extends up to the cortical surface, and from the cortical surface, it is the M4 segments or the cortical MCA. Similarly, the coronal view of an T2 MRI, the same thing has been illustrated. So this understanding of the various segments of MCA is essential in understanding, in order to understand the various surgical steps in clipping the MCA aneurysms. Hope the anatomy of MCA is clear. It's very, very important that you understand the various segments of the MCA. Only then, because in dissecting the MCA aneurysms, there is a proximal to distal approach and from distal to proximal approach. So two various approaches are there. So either you can come dissect along the M3 and reach the bifurcation, or you can go along the or you can go from the bifurcation to the M3. So that is called as proximal to distal approach or distal to proximal approach. So it depends on the projections and your expertise.